welcome to the Home of Medicine podcast with me, Dr. Amy Burbridge. I'm a consultant in acute and general internal medicine in the West Midlands. And over to you, Ben.
Hi, Ben Lovell here. I am also a consultant in acute and general medicine working in London. So I would like to present to you, Amy, a case.
Fab. I can't wait.
So this is a headache case. I quite like, I think I've said before on the podcast, I quite like assessing headaches and working out what's going on, but not everybody does. But it was a 40-year-old woman who presented to ambulatory care, so same day emergency care where I work, and she'd had 2 months of headache, which was pretty bad pain, which she said was right behind her eyes, like a pressure, retroorbital pain. It was coming and going, so it wasn't there all the time, but she had good days and bad days with it over the last 2 months. And it was not thunderclap at point of origin or any point in the story. And she also said that she felt very dizzy with it. And when I pressed her on this, it wasn't vertiginous dizzy, it wasn't room spinning dizzy. She meant lightheaded and generally unwell, just not her normal self. And she'd also had some intermittent double vision. That was her presentation to me. And her big anxiety, which she put up right at the beginning of the consultation, was, I'm 40 years old. This is the age my brother was when he was diagnosed with multiple sclerosis. I can't help be terrified. That's what I've got, because there's a genetic component to MS. And because of the way our system works, by the time I went in to see her, I already had a blood results and they were all completely normal. Renal function, liver function, full blood count, and a CRP, all absolutely fine. Initial thoughts: 2 months severe headache with double vision, intermittent.
Okay, so I'm in ESTEC. I'm going to put myself in your shoes. And the first thing I need to do is make sure this is not a serious cause of a headache. So am I dealing with here a acute subarachnoid hemorrhage? Very unlikely, given the fact that it's a 2-month history. And I would have expected that it would be much more acute, that would be sudden onset, severe pain, not 2-month history. So from the time scale, pretty much ruled that out. It's always going to be at the back of my head, but I'm happy it's probably not that. Secondly, 2 months, headaches, dizziness, generally unwell, double vision. Is there some raised intracranial pressure? So could this be something like a space-occupying lesion? So that's some of my serious causes of headache. So do I need to be thinking about doing a head scan? Is that a potential? 40 years old, she's got a headache. Okay, I say this about every woman, but is she pregnant? Because every woman's pregnant until proven otherwise, so I'd like to make sure that she's not pregnant. Are these headaches, you said, for 2 months? Were they continuous for the 2 months, or did she notice a pattern with them?
She noticed there were good days and bad days,
Okay.
she used the word intermittent with me, but she didn't identify a pattern, i.e. she wouldn't say they were worse in the morning or worse in the evening, and she couldn't notice a trigger for them, so they were patternless.
Okay, so my serious causes of headache then are my raised intracranial pressure. Is this a space-occupying lesion? Is this a subarachnoid hemorrhage? From the history, when I've moved on from that, I now want to be starting to think about, okay, is this a primary headache condition, tension, migraine, cluster headaches, and going down the history taking of that route. However, you did also throw in double vision. So do I have compression at the optic chiasm that is causing a problem? So could this be a pituitary abnormality, pituitary adenoma, potentially? And however, bloods were normal. So by the time it's got to the size of compression of the optic chiasm, I may be expecting some abnormality in sodium and potassium, but I may be thinking a bit too far ahead. And then secondly, you mentioned her brother had multiple sclerosis. So although none of these symptoms necessarily fit, I need to ensure that I take a good enough history and examination to give her some reassurance as well. And then after all that, then part of at the back of my mind as well is, could this be stress related? Although double vision and dizziness isn't normally stress related. So I'm not really thinking along those lines. So that's where I am at the moment.
So when the patient said to me, I think I want to know that I haven't got MS, I can't help but drop anchor on that diagnosis for a while. And I feel like I need to rule this out now for her, obviously, but it's hard not to then go down the right. Let's rule up for multiple sclerosis at this point. So immediately I was trying to fit or unfit her diagnosis into MS. I was thinking, okay, if she's got a new diagnosis of MS, she could have, a inflammation posteriorly in the pons in the brainstem, and that would give her a cranial nerve and that might explain her double vision. I hadn't even assessed her or examined her at this point, but I was thinking, okay, the pons, that's the nucleus for cranial nerves 5, 6, 7, 8. Remember that from the Step song. So maybe if she had some demyelination there, that might be the ophthalmoplegia that she describes, the double vision. Maybe that's giving her vertigo. They said it wasn't vertigo, but cerebellar problems and then headache. If you've got really bad optic neuritis with multiple sclerosis, you can get a really bad eye pain, erect orbital pain. So here's me initially trying to push all the bits and pieces into an MS shape, but not really getting anywhere. But I couldn't help it, because when someone says, here are my symptoms, and is it X? It's difficult not to use X as a framework, I find, and to say, whoa, can we park X for now? I'm going to work this up de novo from the ground up, and then we'll work out if X fits in when we get to X. But I find that quite tricky to do from like a cognitive point of view. So I examine my patient, and she examines really well, actually. The only hard finding I could find was that she had a 6th nerve palsy on the right. So she had horizontal diplopia. And when she looked over to the right-hand side, she went, whoops, there's double vision. And it was very clear. I'm not great at picking up cranial nerve palsy, but I can do a 6th nerve palsy. And the images were side by side, as you'd expect. She couldn't abduct her right eye properly. Okay. So now I'm dealing with a woman with a headache and a 6th nerve palsy. And at this point, I was like, well, we've got to do some imaging. Has she got, a la Amy Burbridge, has she got raised intracranial pressure, either due to a space-occupying lesion or just intracranial hypertension, idiopathic intracranial hypertension? We do know that because the 6th nerve has such a long, tortuous path across the brain, when you have raised intracranial pressure, you can actually develop a 6th nerve palsy, and we call it a false localizing sign. It doesn't necessarily mean the part of the brain around the 6th nerve is affected. It just means the whole pressure inside the brain's up, and the 6th nerve is the first thing to show a hard outward sign. So I said, let's get a CT head, and let's do a CT venogram as well, just to make sure she hasn't got a cerebral venous sinus thrombosis. And they come back pretty quickly. We did the scan, and later that same day, we had a completely normal CT head and CT venogram for this woman with a headache and a 6th nerve palsy. So there goes my theory of a space-occupying lesion. However, intracranial hypertension could still be on the cards. There's only one real way of diagnosing that, and that's by measuring someone's opening pressure on a lumbar puncture. So then I was faced with a bit of a back and forth. Do I want to LP this woman or not? Would it give me the data that I need to move forward with my diagnosis or not? What do you think?
So, did you do fundoscopy?
Yes, and I'm rubbish at it.
Yeah,
But
me
I
too.
did, and I saw clear fundal margins. So I think I can pick up papilledema when I see it, which would be blurred margins of the optic disc. Like they were clear. And listen, I'm going to be absolutely honest here in a safe space. I know you should be able to see the absence of venous pulsations and raised intracranial pressure. I haven't seen it yet, but one day I will. I'm still learning, still picking up skills, even at my advanced age, and one day I'll know what people are talking about, but I couldn't really comment on that. The other signs of sort of when you have optic atrophy, which is sort of an end sequelae of long-term optic neuritis in the term MES, is you get this chalky white optic disc, and I didn't see that, but that's something I think you would see after many years of optic neuritis, if that's indeed what was going on. But there you go.
So, what about her visual fields? You said that though her neurology was normal, does that mean visual fields was okay? I'm just thinking about that compression of the optic chiasm.
Visual fields were fine. So
Okay.
when you get compression at the chiasm, don't you? It affects your optic nerve, right? Cranial nerve, and you would get bitemporal loss of vision. But in fact, it was fine.
Okay, so neurology is normal. She just got isolated 6th cranial nerve palsy. Has she had is there a small infarction in the blood supply to the 6th cranial nerve? I mean, is she diabetic?
She's
Um,
not a diabetic, and yeah, it was literally just the 6th nerve. So, I mean, with the 6th nerve nucleus, we said is in the pons. The course of the 6th nerve
hmm.
is quite long, but so there's quite a big area to have a vascular issue to, I guess, isn't it? And also, I do know that rarely stroke can present
Mm.
with headache, but it's atypical. The brain is insensate, has no nerve end. So to infarct an area of brain, unless then you get really bad cerebral edema and swelling, which stretches your meninges, you don't usually get headache.
Yeah, I guess what would I do next? Hmm. I would probably actually, I'm not very good with nerve palsies. As you know, my self-confessed neurophobia. So a cranial nerve palsy is like up there in the most difficult, challenging cases for me. So I would speak to colleagues, I'd maybe get second opinion, maybe have a chat to neurology. Would it be worth
Yeah,
ophthalmology having a look at the back of the eyes? Because my
yeah.
fundoscopy is not great. So would it be, to get some photographs at the back of the eyes to have a good look? Not sure. What did you do?
I wondered for a while. I had a cup of tea and a think, and I turned it left and I turned it right, and I sort of turned it upside down in my head. And I thought her headache, she describes very migrainous, doesn't really like the light, but not photophobia, doesn't like loud noise, feels a bit unwell and queasy, but a two migraine, you can get rare migraines disorders with neurology. Migraine with, I've heard of hemiplegic migraine before, um, and you can get an ophthalmoplegic migraine, although I understand it's changed its name of late. It's no longer called ophthalmoplegic migraine. We used to call that migraine with ophthalmoplegia, of course. So you'd have diplopia. It's now considered a cranial nerve neuropathy rather than a migraine spectrum, but maybe that's a topic for another podcast. But I wondered if it could be migrainous, but I felt a bit brave saying that without further tests. Basically, I did the lumbar puncture, really, so I wanted to measure her opening pressure. My
Okay.
working diagnosis still raised intracranial pressure, causing a false localizing sinus nerve neuropathy. Yeah. So that's what I did. And her opening pressure was completely normal. It was 14. So we sent the samples off for analysis, as you do, because we'd already had them in our hands. And then I wasn't so sure what to do next. So I spoke to neurology, knowing in advance what they would say, but I ran it by them and they said what I expected them to say, which is get an MRI brain. So we did an MRI brain and brain stem just to get that brain stem in for the cranial nerve nuclei, and it was completely normal. So I was starting to think I have ruled out a few things here. Structural cause gone, raised intracranial pressure out the window, blood clot definitely not. Inflammation and particularly demyelination to address her concerns of MS, the MRI scan says, computer says no. So that's great. What am I left with? I'm left with what sounds a lot like a migraine. So I was tempted then to say, let's give this a bit of time and see what happens. However, the CSF results came back, and I wasn't expecting any abnormality on them. So I was very surprised to see the CSF protein was elevated at 0.74, and the cutoff in our hospital is 0.45. So it was above normal. Her CSF glucose was 3.5, which matched with a serum glucose of 5, so that's normal. There were 86 white cells, which were 80% lymphocytes, mononuclear. So she had a lymphocytic cellular CSF with a slightly raised protein. Does that say anything to you?
I guess thinking of the context that you did the lumbar puncture in. So now you've got a investigatory incidentaloma, haven't you? So did you send off for immunoglobulins in the CSF, just out of curiosity?
Well, we actually sent off oligoclonal bands
That's what I meant, sorry.
because the
Yeah.
question of MS was still
Yes,
there.
of course.
So we sent off serum and CSF oligoclonal bands, and she came back with oligoclonal bands in the CSF and matched in her blood. So that leans away from multiple sclerosis. And also, we had some CSF left over for a viral screen, and they tested it for common viruses, including HSV,
Hmm.
varicella, enteroviruses. Everything came back negative. So at that point, I was thinking about what do I know about CSF, which has white cells in? That to me speaks of CNS infection, of
Yeah.
which to me there are broadly two types: encephalitis, infection of the brain, meningitis, infection of the meninges. Encephalitis tends not to present with headache. It tends to present with, neurology, up to and including cognitive neurology impairment. So like psychosis, status epilepticus, other focal motor problems, because your brain is inflamed. But because the brain does not have, as we said, a sensation, they tend not to get headache in my experience. I'm sure there is crossover and there is some rare cases. Meningitis, to me, you tend not to get neurological findings, just severe pain, because the meninges are packed with nerves and they're very, very sensitive. Kind of meningitis, you've got your bacterial meningitis, fungal meningitis, which I think you only get in severely immunosuppressed patients, and viral meningitis. Now, I know that bacterial meningitis, you get lots of white cells in your CSF, but they tend to be neutrophils, right? Polymorphs. And in viral, you get lymphocytes. So I was left with, is this viral meningitis? Viral meningitis is a self-limiting disease. It's caused by viruses, severe headache. You may get some meningism and photophobia, and you treat it conservatively with painkillers. I've never seen it last 2 months before, and I've never seen it cause any cranial neuropathy before. But the CSF to me was pointing towards that. Then I was given the extended viral screen, including adenoviruses, enteroviruses, Coxsackie virus, echoviruses, any virus you can name that cause viral meningitis, and it was negative. And I really didn't know where to park this now and what to do with that diagnosis. Could it all be infectious? So I called neurology, and they came to see the patient, and the neurology registrar saw them. He noticed that the sixth nerve palsy was slightly improved from when she first presented at ESTEC. This happened over the course of 48 hours. So it's slightly improved from 2 days ago. And his diagnosis was possibly an ophthalmoplegic migraine and a reactive lymphocytic CSF. These were his words. Outpatient neurology follow-up. Patient can go home. And the patient was discharged. I'd left the building at this point because I wasn't on call for ambulatory care the day that neurology review happened. And it wasn't until her CSF results came into my inbox on our electronic system a couple of days later that I read the neurologist's review. I read what happened and that she was discharged, and I felt slightly disquieted by the whole thing. What do you think?
I mean, it's complicated. So we've got what do we have that's positive in this situation? We have a headache, dizziness, double vision, 6 cranial nerve palsy. We have a positive CSF with high protein, which indicates there is some inflammation within the meninges somewhere. We've got some lymphocytes. So to be honest, I'm going to be completely truthful. I hadn't heard of this reactive lymphocytic CSF before.
I mean, I don't even know what it means. I didn't even know what it means. I read it.
Is that?
I read it. I was like, what?
Yeah, is that a reaction because of the migraine? It's not. I'm trying to think pathophysiologically. How would the meninges develop inflammation from a migraine? But that's exactly my lack of understanding. So I'm going to put something out there.
Yeah, I was very confused, and I read it over and over and over again.
Yeah,
and I thought I couldn't. I was saying, was he saying ophthalmoplegic migraine with a reactive lymphocytosis in reacting to the migraine, which is new? I've never heard of migraine causing abnormal CSF chemistry before.
Me either.
Maybe there are some. Or was he saying ophthalmoplegic migraine plus a reactive lymphocytosis in the CSF due to a concurrent infection? It was, of course. I picked up the phone and I rang him. Said, thank you so much for viewing this patient. I just wanted to clarify because I'm not quite sure what the end diagnosis is here, because this 40-year-old woman has gone home with a bad headache and she's got a 6th nerve palsy. And what is she going to get better? And what did you mean by react? Sorry, I'm not following what you meant. And he said to me, oh, well, yeah, maybe she had a viral infection and that's why she got a reactive lymphocyte. Maybe she had a bit of viral meningitis, and that's what she was. And it might be an ophthalmoplegic migraine, or maybe it could be a microvascular 6th nerve palsy, but it should get better on its own. You can refer her to ophthalmic prisms done to correct the diplopia, but I think it would get better on its own. And I sort of came away from the conversation thinking, I don't think we have a clear picture of what's going on here. I very much respect your expertise here, and I did something really, really unusual. Which I count on the fingers of one hand that I've done in my entire career. I rang the neurology consultant and said, I think I would really appreciate if you could come and give me a second opinion on this patient, because I think we're not, as a team, really getting to the bottom of what's going on and managing the case here. And if you think that's unreasonable, could you just let me know, have you heard of a reactive lymphocytic CSF due to migraine before? Because it's just making me a bit nervous. My name is still attached to patient's care. Her results are coming to my box. And we have a very anxious woman out there who can't see properly. She's seen two of everything and she's crippled by a headache, and we haven't really told her why, except it should get better. And the neurology consultant said, bring her back to SDEC tomorrow. I'll come and have a look at it. And I felt so much relieved by that. And I felt a bit silly. And I said, can I just give you a big apology in advance if I've missed something obvious here? And this is all very, very safe. But we've gone outside of what I've seen and experienced before in my career. And that's made me feel a bit unsettled. And I don't think we've quite got the bottom of it. And he was very nice. No problem. Bring it back. I'll come and see him myself, and we'll see if we can work out what's going on.
Okay.
Have you ever done that before?
I mean, I completely understand your point of view, because it didn't sit right with you, and it probably highlights my lack of knowledge, to be honest, in neurology even more. The only other thing I'm thinking is there another line of investigations we should be doing actually with a inflammatory CSF? Do we need to be thinking, ooh, is there something rheumatological going on? So I'm thinking along the lines of, I mean, it's not going to be this, but something like central nervous system lupus. I mean,
The vascularity.
the
Yeah.
vascularity processes, yeah, and which can affect the central nervous system. You can get that protein reaction, again, rare, but is there some other investigations we need to do before we? But what happened? What was your discussion?
Well, I'll tell you one other little thing. I mean, the consultant you've already said on the phone, no, you're completely right. A migraine does not cause a lymphocytic CSF. And she's too young to have a microvascular sixth nerve palsy. You get that in young diabetics, people with autoimmune pathologies, and people with disseminated malignancy, but you don't, and people with severe coronary arteries, but you don't get it in just young healthy people. So he says, I understand why you can. And I asked a question. It took a lot of guts to say it, but I said, also, I wonder if it could be Handel.
If it could be what, sorry?
Handel. I have seen a poster at SAM, the Society of Acute Medicine Conference, the year before, about a case presentation of a woman with a diagnosis of Handel. It's an acronym, HANDL. And for some reason, that case report, that poster stuck with me. I love going and reading the case reports at conference. They're my favorite things to do. I find them so interesting. And I find it so much easier to remember a condition when it's attached to a story, attached to a narrative outcome. And I remember seeing a post about something called Handel. The acronym HANDL stands for, listen to this, headache and neurological defects with CSF lymphocytosis.
I am actually, what do you call it? I'm not the word.
Neurologists love diagnoses which are descriptors of the symptoms, don't they? They love it. And this is one of those. I remember reading it, and I remember reading the case report as a woman who had recurrent headaches, and every time she got a headache, she kept bumping into things. And then they tested her visual field, and they found that every time she had a headache, she lost her field of vision all over on the left and had intermittent hemiplegia. And they eventually came up with this diagnosis, this rare diagnosis, and it stuck with me because I was like, so that's an acronym that I can remember. And gosh, that looks a bit like a viral meningitis CSF, but I guess it's not. So I said that, and he sort of said, well, then anything's possible. But listen, I'm going to come tomorrow and we'll see what's what. But, I made a punt. I didn't get shot down, so I didn't feel too stupid. But there you go. So have a look at your case reports. If you don't read journals because you find them boring, find the ones with case reports in, because there's really good learning from those.
Can I just ask, is this Handel? Is this part of the migraine family, or is it a completely
Amy, nobody knows. Nobody knows. Well, I'll tell you, I'll little Mike maybe in a minute. Anyway, so she came back in the next day, and the consultant came down, and he said, yes, there is still an ongoing sixth nerve palsy. He says, we need to do some more tests. We need to do an MRI with contrast. He said, the thing about Handel is it's very much a disease of exclusion. You must rule out infection. You must have a normal MRI scan with all their fancy MRI stagings and contrast and all that jazz and diffusion weighted imaging and all those things. it has to be headache and transient neurological defects and the CSF pleocytosis without another satisfactory explanation. He says, leave it with us and we'll work on it. And the answer at that point was maybe. And so this is 5 years ago, this case, and I've left enough time here just to make sure that, neurology readers recognize themselves and feel like I'm having a go. But I followed her up, and she was seen year on year in the neurology clinic. They really wanted to nail down the absence of multiple sclerosis first. Her headache eventually resolved, as did her sixth nerve palsy. And she had yearly MRIs as part of their query MS, or clinical isolated episode syndrome workup. And never once did she have a patch of demyelination or inflammation on any MRI. So they put that diagnosis to bed. And finally, in her last clinic, they said diagnosis of likely Handel. Oh, how good that feels. Or from a poster at a conference, which I speed read whilst munching on a croissant and a cup of coffee a year before at a conference. That felt nice. So there is a lesson about ongoing CPD and going to conferences, and a punt for the SAM conferences, the Society of Acute Medicine conferences. I don't work for them. I have no interest in people signing up, but it was very, very, very useful in the long term. So do you want to know a bit about Handel?
Okay, so first of all, I'm still speechless because it's a condition I've never heard of. And secondly, I think you're some kind of genius, because to throw that diagnosis out there and to be right, wow, incredible, amazing, well done. And I think that just continues to reiterate the importance of CPD, listening to podcasts, just things like that, which are always introducing you to new conditions. So can you please tell me a little bit more about Handel? I thought it was candle when you first said it. That shows how little I know.
It stands for headache. Do you know what? And I usually take photographs of interesting posters at conferences, because sometimes I come back to work and I stick them all in a PowerPoint and I show everyone else and say, here's my favorite posters from the conference I went to. And I've been through my camera reel in vain trying to find the actual poster, but I'll tell you anyway, all I remember about Handel, and having, looked it up for this. So Handel has got to be a diagnosis of exclusion. So you need to have, as I said, a rule out infection, a rule out demyelination. And otherwise, the criteria are pretty much in its acronym: headache with neurological defects, which are transient, associated with the headache, and a lymphocytic CSF. 20% of people with Handel have a prior diagnosis of migraine. Is this because migraineurs are more likely to get Handel, or because people with Handel, which can be recurrent or it can be a one-off, are misdiagnosed with migraine from the get-go, and therefore our data is all confused? So you can use, when you're working up your differentials, you can differentiate it from migraine, because a migraine should have normal CSF, Handel doesn't. You can differentiate from an acute, because the MRI with diffusion weighted imaging is normal and it wouldn't be in a stroke. You can differentiate it from Lyme disease, neuroborreliosis, neuro-Lyme, because you can test for Lyme serology. You can usually differentiate it from autoimmune encephalitis, because autoimmune encephalitis usually doesn't cause a headache, and we now have more and more tests that we can do looking at antibodies for autoimmune encephalitis. Differentiating it from infection, that really is a clinical, obvious signs of infection. You're looking for any systemic signs of infection or focus of infection, and confidently rule that out first. Otherwise, you might actually not be looking at Handel. You might be looking at the dregs of a viral meningitis process due to a common virus, which has caused that reactive CSF that we heard about earlier on, and possibly the neurology. Although, have you ever seen viral meningitis giving anybody hard neurological impairment before? Because I haven't.
I haven't. I've seen quite a lot of viral meningitis that's had a lumbar puncture and diagnosed on LP, but also I've probably seen a lot of people with viral meningitis who haven't had the LP and gone home, and it's it's sort of self-resolved. But no, it's not something I see.
Me neither. So it really is to the neurologist to diagnose over time, because it takes time to get all these things ruled out.
Yeah.
But it was fun. It was so fun to have a punt at the front door and a diagnosis. And I think that nobody minds anybody doing that. In fact, people love it when someone nails their colors to the mast and says, could this be this, right from the get-go? And if you're wrong because you didn't have the data yet, then who cares? And if you're right, well, that's a nice feeling, and there's some job satisfaction in there. And people should make sure they are looking case reports, going to conferences and getting this information, staying up to date, and writing these case reports as well. If you've seen something really interesting and unusual at work, it's not just writing up because it's credits on your CV, but people like me bumbling around with a cup of coffee at a conference will see it and then apply it in clinical practice somewhere else, which is really, really powerful. And, you could look at this podcast that we're doing now and calling it, case reports, the case report podcast, because that's what we're doing really. But hopefully somebody might pick something up here and move it forward. And somebody has, they've definitely given us feedback. Do you remember the podcast episode we did about the swollen leg? Somebody contacted us and said, the next day I saw this condition and I knew what it was.
Yeah.
So there you go. You have to keep sharing the work.
Yeah, absolutely. So practically, from a handle perspective, is there any particular management if it becomes chronic or recurrent?
It's absolutely self-limiting and benign. And episodes, if you do get concurrent episodes, are just really treated with observation, knowing that it will go away again. There are some people, when I was looking it up this morning, who are treating it with usual migraine prophylaxis. So talking about your topiramate, your candesartans, your propranolols, because they feel it is a migraine spectrum disorder. But the jury's still out. I mean, even looking to see what is the pathophysiology of this, the jury's still out. They don't know if it's vasomotor. They don't know if it's cortical spreading depression, which is due to neuroexcitability spreading around across the brain. I do know that they see it more often after viral infections, which could be a trigger. So that makes the diagnosis really muddy. But yes, it's still a controversial in terms of pathoetiology.
Is it more common in women?
In younger cases, in pediatric cases, it's common in female patients than male, but in the adult population, it has a male preponderance.
Ooh, like cluster headaches tend to have a male preponderance.
They do, yeah.
Okay. Wow. Thank you. Yeah. And it also makes me think about, how many people do we see with headache? So many people. And I wonder whether actually I've missed a few cases of handle. And I wonder with my cognitive biases, how many patients I'm going to diagnose in the next few months with handle. Be complete. Or I'm going to mention it and say, this could be handle to make myself sound really clever, but I actually just sound like not very clever at all. Thank you so much. That was really interesting. And you've reiterated the importance of good history taking. Thinking about diagnosis of exclusion is a diagnosis of exclusion, and making sure you've excluded everything else. And the importance of case reports. And like you say, going to conferences, reading journals, listening to podcasts to continuously be learning and continuously be doing our CPD. So brilliant. Thank you so much. Thank you so much to everybody for listening. Please rate, review and share our podcast. And please drop us an email or tweet us if you've got any suggestions for future episodes. Thanks for listening. Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.